Hi, everyone. Thank you for joining us today. My name is Michelle Proser. I'm the Director of Research at the National Association of Community Health Centers. My name is not on the slide right now. I'm the Project Director for the PREPARE project, and as folks may know, PREPARE is a national collaboration between NAC, the National Association of Community Health Centers, as well as the Association of Asian Pacific Community Health Organizations and the Oregon Primary Care Association. And we work with a range of health center network, and state association partnerships or partners as we design and develop this. And we work actually with a wide variety of others as well. We're really excited to talk to you about our risk stratification work today. This work is important. It is designed to help improve how care is delivered, improve health equity, and really drive value in care, really ultimately what the PREPARE is meant to do. Our work is innovative, it's groundbreaking, and we think there's a lot of interest in it given that we've broken some records in registration for this webinar. There are far more than 600 people that have registered for this webinar, and given the turnout, we have decided not to do any live polling or Q&A, and we will not be using the chat function to accept questions. We apologize for that, but we've decided there's just so many people on, it's going to be hard to manage. However, instead, we will be sending folks a follow-up survey or poll, and we think that's going to be a really important way for us to engage you. We ask you to complete that poll or that questionnaire when you get it, so that we can get stakeholder feedback on this work and we can understand what your questions are and work to respond to them. This slide kind of gives you some of the background on this webinar, again, the follow-up survey. The chat box can help with questions or comments, but again, since there is such a high volume of people on this webinar, we will do our best to get back to you, but the best way to do that is to respond to our poll afterwards. And there is an email to connect with if you ever want to sign up for PREPARE updates or if you're having any technology issues on this webinar. With that, let me turn it over to Rosie Cheng-Weir, who is the Director of Research at our partner at the Association of the American Association of Asian Pacific Community Health Organizations, APCHO, and she is our co-PI for the PREPARE project. So let me turn to Rosie so she can walk us through this really groundbreaking work.
Great. Thank you so much, Michelle. Again, my name is Rosie Cheng-Weir. I'm the Director of Research at APCHO and co-PI of the PREPARE project. So today, we look forward to discussing work that we've been doing since the beginning of summer to build a stakeholder-vetted risk stratification model that incorporates social determinants of health data to improve health equity and demonstrate value. We'll talk about what we've been able to accomplish through our learning collaborative and hear from one of our collaborative members, Lucy Sines from the California Primary Care Association, to showcase how this work is important for their organization, their state, and beyond. So let me do the slides. And we wouldn't be here without our PREPARE project partners and our funders. And so this is thanks to funding from Kresge. So I just wanted to acknowledge that. So first, I wanted to start out by defining risk stratification, as it's sometimes confused with risk adjustment. So risk stratification is an intentional, planned, and proactive process carried out at the practice level to effectively target clinic services to patients. So risk stratification is a process or tool for identifying and predicting which patients are at high risk for care management and is used at the clinic level, whereas risk adjustment is a method to offset the cost of providing health insurance for individuals who represent a relatively high risk to insurers, and it's typically used at the policy and payment level. So for example, this picture represents risk stratification as it separates high-risk patients from the other levels of risk. So for example, Joe has certain risk characteristics that put him in a very high-risk group, whereas Jen is at a lower risk based on these same characteristics or algorithm. Clinics use risk stratification to help them identify the right level of care and services for different patient risk groups so they can maximize efficiency, improve outcomes, and deliver value. So for example, clinics typically vary their monitoring and care delivery based on these different groups, providing more attention to the highest risk groups to improve outcomes and prevent high costs. So overall, risk stratification is used to identify high-risk, high-cost patients, to understand why they're at high risk, and coordinate interventions to appropriately care for those patients. Some other reasons clinics conduct risk stratification are to better inform the staffing, as well as how to allocate resources and manage panel sizes to be able to provide better care for patients. And so why are people, again, interested in risk stratification? Because, literature shows that a very small portion of the population accounts for half the cost. So if we can help address care for these patients, we can presumably reduce costs as well as improve health equity by addressing the needs of these most complex patients. Risk stratification that particularly incorporates social determinants of health is also important in positioning health centers for sustainability, especially as health centers are held accountable for their outcomes, the shift in value-based payment, and greater demands for evidence. We also know that traditional risk stratification models have emphasized clinical conditions and downplay the impact from patient social determinants of health barriers, and thus don't really have the optimal performance for predicting complex patient populations that health centers traditionally serve. So the environment, combined with the recent growing emphasis on social determinants of health, has really spurred a need for tools to stratify patients by social risk to address the risk, as well as to document patient complexity and demonstrate value. So this is where PREPARE plays a very important role. PREPARE, as Michelle mentioned, is a collaboration between NAC, ACCHO, and OPCA, working with other health center stakeholders. PREPARE, which stands for the Protocol for Responding to and Assessing Patient Assets, Risks, and Experiences, is a nationally recognized and standardized patient risk assessment protocol that accounts for patient social determinants of health and is the leading social risk screening tool used by health centers and Medicaid managed care organizations. PREPARE was designed to engage patients in assessing and addressing social determinants of health. It's evidence-based and stakeholder-driven, containing measures on 21 social determinants that align with national initiatives, such as the IOM recommendations, and maps to other codes as well, including the ICD-10, SNOMED, and LOINC, and also has been translated in multiple languages. PREPARE includes 17 core and 4 optional questions. So we won't have a chance to go into further detail about PREPARE, but there are plenty of resources on the NAC website, including a 10-chapter implementation and action toolkit available online if you'd like to learn more. So as we were finding that many health centers and some state primary care associations were already using PREPARE in risk stratification, we launched a PREPARE Risk Stratification Learning Collaborative to improve our understanding of organizations' best practices and lessons learned, as well as how organizations apply and use PREPARE risk stratification within their clinical settings. We also explored the development of a common national standardized risk stratification model with options for localized methodologies building off their existing strategies. We saw this as an important process to incorporate the community voice, that is, for community stakeholders to be able to weigh in on what is most important in predicting risk for their patients, as community health centers serve the most underserved and complex patients in the nation. Overall, the outcomes of our learning collaborative were to develop a core national standardized risk stratification model with optional measures that could be tested with PREPARE data, a publication on best practices and lessons learned, as well as a plan to test the predictability and clinical utility of the risk stratification model incorporating social determinants of health. First, I wanted to acknowledge all the brilliant minds of the learning collaborative teams listed at the top there. We couldn't have done this work without each and every one of them. So here I just wanted to show that we did a crosswalk of the team's strategies for risk stratification and familiarized ourselves with each other's strategies in the very beginning. Again, we really wanted to uplift their community voices to hear from the on-the-ground experts and incorporate their input into the stakeholder-vetted model. So we had combined this crosswalk with an environmental scan that we conducted of strategies that incorporate social determinants of health in risk stratification. Through our collaborative, we found that health centers didn't feel that some existing risk stratification models were well suited for them. So for example, they believed that some of the HCC and ACG models were tailored to payers and perhaps too heavily weighted on conditions that were not ambulatory care sensitive. So here is what we heard from the community stakeholders in regards to what they wanted to see as we developed the model. So they wanted to use multiple sources of data focusing on the social determinants of health. They wanted to make sure that we had a balanced model that includes separate components for social determinants, clinical, behavioral, and utilization that culminates in an overall national standardized risk score that could be used for national comparison. They wanted the algorithm to be automated. They also wanted to make sure that we use reliable national standardized data. And then flexibility was also really important to the learning collaborative team. So this is why we developed options for a localized model at the clinic level, which I'll go into more detail about later. The learning collaborative also wanted to ensure we uplifted community perspectives in our consensus stakeholder process with an understanding that the model can be modified based on our later validation analyses. In addition, they wanted to start with targeting the general population of patients using metrics that apply to every person. So in terms of the principles that were important to them, they emphasized the following. So first, we intended this risk stratification model to inform but not replace clinic care team judgment. So ultimately, the purpose of this model is to use a quantitative algorithm that is efficient in identifying and addressing high-risk patients who need care most. But both the quantitative algorithm as well as review of the risk groups by clinic staff and the care team should be used in the ultimate decision-making of the groupings. And this is called a hybrid approach, as it emphasizes both sets of the quantitative algorithm as well as the qualitative clinical judgment in identifying the complex patients. In addition, we didn't want social risk stratification to replace social risk screening. So in fact, social risk screening is a precursor for this risk stratification modeling. In addition, they wanted to make sure that we develop a national standardized numeric score that could be used for comparisons important for policy and payment implications. We also emphasized the need for the local clinics to decide on the risk group cutoffs based on their own clinic or community resources. In the algorithm and visualization, they also wanted the 4 components to be organized in categories to better understand aspects of each component for each patient to target, to be able to target appropriate care. We also saw the importance of developing a simple point system to be useful at the point of care with a higher score representing a higher risk patient. And finally, they recognized the importance of, of being able to test and validate the risk model. Okay, so here's the model as a whole. So first, the target population, as I mentioned, were important in the principles slide, was that we start with the general population of adult patients. The top risk stratification goals are to identify the complex patients to facilitate appropriate interventions, primarily for clinic use, and also as a secondary goal to demonstrate complexity of patients. And so overall, the stakeholder model includes 4 components: clinical, behavioral health, social determinants of health, and utilization. We developed the risk stratification process steps, of which I'll provide more detail later. And so the groupings we ended up with were classified as urgent need, high need, moderate need, and low need. And then finally, we also discussed recommendations for resources that should be provided to different risk groups, which we have a start on, but we'll be working on more in the future. Oops. So here is a more detailed look at the model. It includes the 4 components I mentioned, defined by the measures you see here. So as you can see, there's 7 domains in clinical, 7 in the behavioral, the mental health, and substance abuse. The Learning Collaborative preferred to focus on the social determinants of health component and identified 7 clusters of social determinants of health, based in part on our past social determinants of health cluster analysis that we conducted. We conducted a webinar describing this cluster analysis just this last October. In case you'd like further info about that analysis, you can find that recording online on the NAC website. We also recently did some analyses that supported this social determinant scoring, although we acknowledge there is much more validation analysis to do. Finally, the utilization measure includes both emergency department visits and inpatient hospital stays. In terms of weighting, each component has a 20% weight, except for the social determinants of health category has the most weight, double the other categories. And so each of these components provides a maximum score of up to 5, depending on the intensity of the patient's condition within each component. Each of those scores are summed to a total max risk score of 25. And our cutoffs you see there were chosen with a guideline based on the property of the normal distribution, so that the urgent risk group is about the top 2.5% of all cases. The high risk group is about 13.5% of all cases, and so on. Again, with more data, we'll be able to better determine these appropriate weights and cutoffs as guidelines. So during the Learning Collaborative, we conducted some PDSAs, or Plan Do Study Acts, of the various iterations of the model and made changes based on the results. So we developed this risk calculator that you see here that was used for this purpose. The purpose of the validation of the PDSA was to ensure that what we're proposing in our components is truly predicting high-risk patients through the various iterations of the model. So as mentioned earlier, our Learning Collaborative teams emphasize the need for a local model option. So according to participants, the risk stratification model is helpful to standardize the national risk score, but local organizations on the ground should determine which patients belong in which risk groups given resources and capacity available. So we use these principles to develop this local model option. So together we propose to use what we kind of called the slider approach to slide risk cutoffs to wherever local clinics are comfortable based on a variety of reasons, including resources available in the community. For example, if the clinic has less time and capacity and resources, the clinic can slide the cutoff line so that, for example, the number of highest risk patients that need immediate care can be lower. And other potential options for local consideration could depend on interventions and enabling services available at the community and clinic. They can also vary weights of components or perhaps include only certain prioritized target population groups. So here is the process for the risk stratification and segmentation into the groups, as I previously referred to. So the first step is to compile data from active patients having a visit in the past year, assign a score for each of the data components, combine and calculate total risk scores for each data component for each patient, sort by the total risk score and stratify patients into the risk groups. Then the clinic team huddles to validate the risk groups. This is the hybrid approach that I mentioned earlier. And then finally, use the risk groups to target interventions based on the risk groupings. And you can use the guidelines if needed, but users also have a local option to vary the cutoffs of the risk groups based on, again, their local situation, their capacity for interventions, for example. And then you can also use the standardized total risk score for the national comparison, so you have both. So again, I wanted to emphasize here that the national standardized total risk score can be used primarily for the national or state comparisons and for policy payment discussions, whereas the localized risk groupings can be decided by the local clinic based on the resources available in the clinic's capacity. And so this goes along with our principles I described earlier that, the standardization is important for policy and the localization is important for informing care. And this is also consistent with our Learning Collaborative principles to have a national average for each category so clinics can see how they're performing in comparison to other providers or clinics nationally, as well as that local option for flexibility for local situations. In the future, we are interested in incorporating social interventions or enabling services, what we call enabling services, in future risk models. But currently, there's not enough widespread data to do so. And then at ACTSHO, we've already developed a protocol to document these enabling services and interventions, and I wanted to share it with you in case you haven't seen the data collection resources available on the website, enablingservices.actsho.org. And again, actually all of these are also available in the Chapter 10 of the Prepare Toolkit on the Prepare website, nac.com/prepare. Similar to Prepare, who had developed these enabling services or intervention collection resources in partnership with a variety of community and clinic stakeholders and national partners. And so again, once we have this interventions or enabling services data on a more widespread national level, this would be very important in including in our risk stratification model as well. And with that in mind, here's a look at little further look at the data collection resources for the enabling services protocol, data collection protocol. Again, you can visit the website indicated there for more information. So finally, I wanted to address the question about how users would apply the risk stratification model. So we went to our experts in the Learning Collaborative, and here's what they said. So first, you can use the model to improve care management interventions to meet the needs of patients in the various risk tiers and make important decisions, including interventions offered based on the level of patient risk, and correctly assign the limited staff and resources for the highest risk patients. They'll also find it useful for standardization and national comparison, as mentioned earlier, to help illustrate the complexity of our patients' social determinants of health barriers, to inform value-based care, to qualify and be recognized for this work for patient-centered medical home and quality incentives, and to inform payment and policy, such as risk adjustment of social factors that will be key to payment and delivery reform that some of the states are working on. So what are our next steps? So we're working on pilot testing this risk stratification model. Some of our Risk Stratification Learning Collaborative members have expressed interest in helping and doing this with us, so now we're planning for this. Simultaneously, we're working on a wider Prepare national analysis strategy with a plan to test the nationally developed risk stratification model with a larger patient-level data set. We're also working on publication on best practices and lessons learned from this valuable experience, as well as developing resources to help users with the risk stratification model implementation, such as workflow use case scenarios, intervention recommendations for the different risk groups, visualization examples, et cetera. And so here is where you can get a lot more information on both Prepare as well as the enabling services interventions protocol implementation. So feel free to encourage you to visit those websites to find plenty more information. So now it's my pleasure to introduce Lucy Symes, Assistant Director of Data Informatics from the California Primary Care Association. She's a very valuable member of our Learning Collaborative, and will talk to you about the use and application of this model in California. Thank you so much.
Thank you, Rosie. So I am very honored to be on the call today to talk about California's work. So I think Rosie did a really good job at describing the specifics and details of the larger national model for the risk stratification. I'm going to just talk about overview on why California decided to apply to participate in this learning cohort and why we went on this direction. So in the next slide, I think it's important that we talk about, if you can advance the slide, Shell, that'd be great. Shell, awesome. So I think in the previous slide, I want to make sure that we mention the partners that went into this work. It was California Primary Care Association, as well as the consortia of Los Angeles County, and then one of their health centers, Northeast Valley Health Center. Northeast Valley Health Center was actually the clinic that was really involved with doing the PDSA cycle and really involved with the actual patient work. So very thankful for our partners there. And then also NAC and APJO and Oregon PCA to be able to help us kind of start to learn this more and really value our opinion in this learning cohort. So just kind of why risk stratification in California, I always want to start with the quadruple aim. I think that it's important to always put things into perspective in terms of that way. It really allows us for community health centers to provide targeted care for the patients. And when you are providing that care for your patients, you're going to definitely improve their outcomes, as well as improve the provider experience, as well as the staff experience, because they feel that they are making a difference. And then also patients are going to be happier. So that's definitely something that we always want to achieve. And then in the long run, we want to lower the cost of care by helping those high-risk patients that we're identifying through risk stratification. I'm a big, strong believer in standardized data. And so we initially started the Prepare, collecting social determinants of health through Prepare, largely because it's standard, it's data that's actually reportable. My background is in epidemiology and biostatistics, and so I believe that standard data is the key to running any sort of analytics, running any sort of risk stratification algorithms. And so we are definitely interested in the learning collaborative because we are using standard data to make these decisions and to stratify patients according to risk. Also, it's a way to make comparisons across state and local areas, and so we at CPC do a lot of policy, a lot of advocacy, so I think that's definitely a way to compare ourselves in California to national as well as regional. And then also additionally, Rosie touched a little bit on it, was using the qualitative and the quantitative data. I'm a big quantitative data person, but from the learning cohort, we really learned that the qualitative piece is also a really important part of risk stratifying patients. And then designs need-specific care interventions. So from the standardized data, we're learning from implementing Prepare that this data is really informing patient care at the provider level, and then also now at the regional and the state level. So we have really formed relationships with identifying what resources are needed to meet the needs at the local level based on what is coming out of the Prepare risk screening assessment. And we have been really doing a great job with spreading the work on Prepare and really assisting and supporting our health centers to jump on the bandwagon and really start to use Prepare within their EHR system to collect the data. And so this map shows the state of California, and it's highlighted by the consortia. Those are the regional partners that we have across the state. And then it's showing you all of the community health centers that have implemented Prepare. And so these health centers have either gone through a learning cohort with NAC or have gone through the learning cohort with CPCA. So they're starting to collect data. We have over 100 health center sites. It represents about 20, 30 organizations in California that are starting to collect this data. So we really felt strong in that area where a lot of the health centers across California are really starting to use the data and collect the standard data that's in a reportable format. So definitely really feel that Prepare is going to position us for risk stratification. So the next slide talks a little bit about what we hope to achieve out of participating on the Learning Collaborative. So we applied, as I said in the beginning, to be part of this collaborative because we have a large state. There's over 1,300 health centers that we have to work with. And so we wanted to be able to involve California in really developing, refining, and piloting a collaborative risk stratification process for social needs. So we were very honored and happy to be part of the pilot and really excited to contribute to the unified voice of forming the national model. Additionally, we wanted to support our members in improving outcomes for patients. And along with that, it's really about the spread. So when we joined on collecting data through Prepare, we really wanted to spread that work across California. As you saw on the previous slide, we're really spreading data collection using Prepare. And so our hope is to really start to use the risk stratification model that NAC and the team are developing and really spread it across California and in turn, just to be able to provide that quadruple aim, because that's what our mission is for, to help our patients. And what did we do? In the next slide, it's talking a little about what we did to position us for the achievements. So our state is a little bit more complicated. We have consortia across the state, which help us really help the health centers. It'd be hard to just have the PCA be able to make a difference across all the health centers in California. So it's not, if we didn't have our regional consortia, it would be very difficult to help all of the health centers. So the consortia are really helpful in this effort. And so we wanted to include the consortia and then also our health center partners. So developing those relationships was really important. And so we did that by including a health center and then also one of the larger clinic consortia in California. And then we collaborated with partners to provide input on the model. We shared the work with different health centers here in California. So we just really did a lot of communication and really tried to ensure that health centers were part of the conversation. And then PDSA cycles are one of the clinics, Northeast Valley Health Center. They focused on their diabetic patients. And so they had a lot of really good feedback in terms of conducting those PDSA cycles, and had feedback that I saw part of the Rosie slides that were really helpful. And then really listening to your health centers. I'm big on making sure that we're a team and that we all have a voice in this. And so health centers, I think, are really important to ensure that you bring them on board to be able to provide their opinion and their skill set, because they are the experts. They're the ones on the floor. So we really value the opinion of our members. And so that's one of the additional things that we did to position us for the achievement of this work. And then we wanted to talk a little bit about the application and the use of the risk stratification model in California. So I think, as I said before, we're able to use the standardized model to be able to compare across states and communities on the types of social risk factors that are being faced by different populations. We really can create some benchmarks for state-specific or nationwide. I think that is to come, and we're very excited about that. There's multiple ways that you can calculate weight and values for each response and tally those up, or CHCs have the opportunity to tally up the questions into clusters, which I think is really important. It's all about the community health center patients. That's why we're all here. So really differentiating the patients seen at community health centers, show how community health center patients are really complex. We're seeing these Medi-Cal patients that are definitely in need of more services in regarding to social needs. So definitely, we're applying it there. Targeting patient care, meeting patients where they are. We touched on a little bit in the beginning part of this webinar is, not just running the algorithm and not thinking about the patient. I think it's, if you run an algorithm, you're going to create a mark, you're going to create an actual value for that. They're really not just taking the value and going with it. I think it's taking the value, seeing your patient, because that's who truly matters. And so seeing your patient and basically saying, does this really apply to the patient? Is this patient really high risk? Is it low risk? So really trying to figure out where patients are, and just have to meet with them where they are. And then spreading across the state. That was one of the things that I'm a big proponent on, is we're in this together, and the more we spread it, the more difference we're going to make for our patients. And so I think that that's also one of the biggest things that we are doing here at California. And my recommendations to you on how to getting started and why, I think I touched a little bit about this. One thing that I don't have on this slide that I want to comment right now is really thinking about, sometimes you're running all of these numbers, you're running these reports, you're running, these algorithms, and you're seeing all of these reports and analytics. You always have to step back and think, why am I really here? So it's because of patients. That's why we're all here. We're here for the patients. We're here to make a difference in that person that's homeless and is not getting the necessary care because they live out of their car. They're not able to take their insulin because they don't have a refrigerator. So I always really start to think about, why you're here. I think that's definitely why one of the things we need to focus on before we get started. And then also collaborating and partnerships, they're really crucial. So getting to know your members, if you're a PCA or if you're a health center on the line, know who your members are if you're a PCA, or if you're a health center on the line, know who your patients are, get partnerships with, your actual staff, and even your partners like community-based organizations that are in the community that are going to help you provide the resources for your patients. And then also supporting your health centers with standardizing the social determinants of health data. We in California, we really saw the value of using Prepare as the standard tool to collect the data. So if you're a PCA, I recommend you to really work with NAC and APCHO in Oregon to really implement Prepare at your health center. Use the implementation and action toolkit. That's really helpful to implement Prepare, because that's where it starts. You have to collect the data before you go into risk stratification. So really provide that support to your health centers for standardizing the data. And then starting small and conducting PDSAs that are really going to help you test the model. That's kind of how we say about Prepare. You have to start small. You don't want to kind of provide the screening tool to the general population. You might just want to start with your diabetic population, which is what Northeast Valley Health Center did in this learning collaborative. So these are kind of my recommendations to you to be able to start with the risk stratification, as well as starting collecting data if you haven't started already. And the next slide just kind of shows my information if you have more questions. Thank you.
Thank you so much, Rosie and Lucy. Well, folks, it looks like we actually have a lot more time in this webinar than we planned, which is very exciting, because I think this opens up the opportunity to hear more from you. As Rosie and also Lucy mentioned, stakeholder feedback and stakeholder involvement is really critical to this process. It helps inform the development process. So with that, we're going to go ahead and pose some questions to you through a Menti structure. And let me turn to our colleague, Shell, to see if she has that slide. Here she goes. We're asking folks on the webinar to go to that website that you see above. Oops. It's called menti.com, MENTI.com. Type in that code. And we're going to do a quick test, which is just your name and organization. We won't show all of these. Okay. Seeing some old friends and some new ones. We're going to give folks a chance to do that. So as folks can see, this is how Menti works. With the volume of people on this webinar, we will not have the chance to really pull out thematic, some of the common themes that we'll see in the questions that we'll ask next, but you'll be able to see what other people are thinking in terms of the model. We'll give folks another chance to weigh in and let folks say hi to their friends and colleagues. Okay. And Shell, when you think we're ready, we can change the screen. Okay. All right, here is our next question, and there's the code. On a scale of 1 to 5, 1 being not at all comfortable and 5 being very comfortable, tell us what you think about this model so far. How comfortable are you with the national model with local options presented? Okay, in this case, it'll be pretty easy to talk about the general theme because it's one number. Folks are feeling pretty average about it, and I think that's okay. I think there's a lot more that we have to share and show and test.
Michelle, this is Shell. We might want to keep it open a little bit longer. That number of the amount of people coming on is moving up so fast. So it's at 73 now.
Okay. Yep. Okay. And folks can go back to past questions, right?
Yes.
Okay. Perfect. So then I will bring on the next question, Shell, when you switch the screen.
And Shell, do you want to hover over the number just to show the breakouts?
Mm-hmm.
Oh, perfect, thanks.
See our dispersion. That's great. And Rosie and Lucy, feel free to chime in as well. Okay. This is kind of like popping popcorn in your microwave. When it starts slowing down, it's time to switch to the next question or take the popcorn out of the microwave. Okay. What, if anything, would you change about the national model with local options presented? Give folks a chance to think about it. And you can also pose questions. Very fair. It's hard to really talk about this without more detail. Automatic, we agree. Having it something that can be automatically delivered on or scored for patients would make it a lot more easy. Okay, well, clearly we're not giving folks enough time to weigh in, and that is fair. Overlap. Folks, and also I think the person here who said we haven't tried using it, I think that's also a really fair point. It's one thing to weigh in on something that is conceptual, and it's another thing to weigh in on something that you tested. And in our Risk Stratification Learning Collaborative, we actually had some PDF cycles to develop it, but perhaps that's something we need to think about moving forward.
And this is Rosie. I just wanted to mention, we will we're working on a publication, and we'll provide more of those details within that publication as well.
But great to know there's a lot of interest out there. So folks want to see how it compares to other risk stratification models out there. I see those comments. That's helpful. Alignment across assessment tools. Some suggestions for how we test it on the impact side. Some questions about whether there's too much flexibility. Okay. So our next question, how would you apply a national model? So for those that are thinking about standardizing data across multiple partners, this might be a good question for you to weigh in on. Or for those that are looking to benchmark themselves against other providers, maybe. Not sure if used in pediatrics. An interesting place to test this. Yeah, would like to see how it looks when applied to different populations. Some helpful tips, but other sources to look at. That's always appreciated. Involve more CBO stakeholders. Conversations at the national level with payers. Okay. Rosie, anything else you want to chime in on? Or Lucy? Nope.
No, it looks great. I look forward to combing through them.
All right, so how would you expect health organizations to use a local model? Sounds like folks are still digesting this one, and that is totally fair. Aligning needs with available resources, absolutely. And this feedback, as Rosie pointed out, it's very helpful to inform our use cases, and I think those use cases guide us in design. Where to involve community health workers, basically how to prioritize your interventions and the different services you have and resources that you have to plan. See a lot of common themes here. Drill down to specific populations and look at their differences in terms of their needs. To look at it from a systems perspective in your community. Okay. Rosie, anything else you want to add?
No, it looks great. I see some alignment with what our Learning Collaborative's thinking and some other areas that we need to consider, so it's great.
And we're definitely hearing there's a lot more. Sorry, Lucy, go ahead.
So I just wanted to say that a lot of this is, a lot of what I'm seeing responses, it's a lot about resources, and so I think that that's definitely well taken. I think a lot of the resources are going to come out of the Prepare screening tool, but now with the high risk, I think that just adds another level to it. So definitely good information.
Absolutely. And we're definitely hearing that there's an interest in learning more about our model, and so we're excited to put more information out. Okay. Shel, was that the last question? I've lost track.
Yes, so. Yep.
Great. Well, thank you to all of our speakers, especially thank you to our speakers, Rosie and Lucy, and for everybody who's attended and a lot of the questions that have popped up. We're going to do our best to get back to folks. Rosie and Lucy, do you have any other comments or are there questions that are popping up elsewhere that you'd like to address?
Not that I can.
This is Lucy. I don't have any. I just think that, definitely keep providing your input to the folks on the line, to NAC, to Michelle and Rosie. I think that they are really crucial in kind of taking your information and your thoughts and applying them to the national model. So definitely keep in contact with the NAC folks to make sure that you are voicing your concerns and your questions are addressed in the national model.
Mm-hmm. Yes, it's Rosie. I completely agree. I think this is really, getting all of your feedback here is really important for our efforts moving forward, so I really appreciate it. And as Lucy said, keep in contact with us, keep us updated with what you're doing and what your interests are and potential changes or other aspects that we need to consider within this model.
Mm-hmm. Absolutely. Perfect. Okay, great. And I'm just looking at some of the questions here. I do see two that we could probably quickly answer in terms of external companies and vendor support and advocate for Prepare. I'm not entirely sure if I understand where that question, but what I can say is a lot of vendors are very interested, and a lot of them are building in the Prepare tool, and they're looking for guidance from us based on our experience on how they can be building in risk stratification too. So as somebody mentioned the Menti, that making it automated is really critical. That is something that vendors are also eager to do, and we're very excited to partner with them on. And does anyone use NextGen and establish a scoring system? NextGen does have Prepare built in, and I believe right now they're using just our Prepare tally score, so you can find more information on our website or through the NextGen team. And I think those are, unless there are any other questions, we do.
Yeah, and there were some questions about the coding, enabling services coding, and just feel free to, hop onto the website, enablingservices.opshow.org to be able to find out more, or Chapter 10 within the Prepare Toolkit at nac.org/prepare.
Mm-hmm. And for the person asking about the pre-screen, the risk stratification model is based on the full tool. But as Rosie talked about, Rosie, do you want to talk about the buckets again?
Sure. So as I mentioned earlier, a lot of this, we developed clusters of Prepare social determinants of health based on our previous work. And as I mentioned, that's you can find more detail. We did a whole webinar on it last October about those analyses. And so we based it a lot, in part based on those, the results of those analyses. And so there's 7 clusters. There's it is based on the full Prepare tool. And for how we've developed the scoring for that is that, you can, if you meet, so this is, just to give you a little background, the cluster analyses are based on factor analyses, which means that a lot of the items within that cluster are intercorrelated with each other. They tend to go with each other. So if you have, for example, if you're uninsured, then you're likely, that's related to being unemployed. So because it's based on this factor analysis, a patient would need to meet one of those domains to be able to be counted for a risk within that cluster. So that's sort of how we base that, and along with a lot of the stakeholder feedback and opinions, we formulated the clusters within that social determinants of health component. And so, let's see, I'm wondering if I answered the question, but yeah, for further information, you can contact us. But yeah, that was, a lot of what we focused on was that social determinants of health component, and we tried to build on a lot of the analyses that we had done in the past. Yet we recognize there's a lot to be able to a lot that we need to do to further test this risk stratification model as a whole, including the other components within the model, and that's what we plan to do in the future.
Great. Well, with that, we will go ahead and sign off. Thank you again to Rosie and Lucy and to everyone who joined us. If you're not already on our website, please make sure you visit that at nac.org/prepare, and keep in touch through prepare@nac.org. Thanks again.